Hello, this is Dr. Bernstein with our March 2021 edition of Dr. Bernstein's Diabetes University. Um, Before we get started, I'd like to comment. I've had comments on the messy background to my videos. So we were initially thinking, several people actually suggested I have an American flag behind me, but since our audience is international, I elected not to do that. Instead, I put up a T-shirt um, uh, developed by the Nutrition and Metabolism Foundation, and it says on it, I get my carbs from from GNG, which is gluconeogenesis, which is the conversion of protein to carbohydrate. And basically, the Nutrition and Metabolism Foundation has long been advocating what I've been saying since 1975, which was have a lot of protein in your diet if you're diabetic, and the protein will be a source of as much needed carbohydrate, as much carbohydrate as you need if you eat enough protein. So I get my carbs from GNG, gluconeogenesis. And on the subject of gluconeogenesis, in a current issue of the journal Diabetes Care, we can read this title: Gluconeogenesis but not glycogenolysis contributes to the increase in endogenous glucose production by SGL2 inhibition. Now, you may recall that there's a class of drugs being widely promoted for type 2 diabetes called SGL2 inhibitors. And these medications cause the release of a lot of glucose into the kidneys, and the kidneys then pee away the glucose, thereby lowering your blood sugar. And you may also recall that I've been prejudiced against this drug or class of drugs in spite of many I should probably say most authorities in the field advocating its use, because some studies have shown that they, over time, reduce the incidence of coronary artery disease and may even reduce the severity of kidney disease. I just don't like the idea of putting a lot of glucose through the kidneys. And here, this article says that this class of drugs raises blood sugar by gluconeogenesis. That is the breakdown of protein in the body. And where does this protein come from? Probably amino acids that are derived originally from muscle. So this is breaking down muscle, turning it to glucose, and eliminating the glucose in the urine. But it also doesn't just eliminate that glucose. If you have a high blood sugar to begin with, it probably eliminates the high blood sugar that you had. So that's why it's used. But the fact that this causes gluconeogenesis, the breakdown of your own body proteins, sort of bothers me, and probably should bother potential users. But I'm not certain. This is just an opinion. We have another article that's current of new ADA guidelines for blood sugars in young people, children, and they're now seeking blood sugars less than seeking A1Cs less than 7% in children unless they cannot tell their parents that they're getting hypoglycemia, in which case they make it 7.5%. 7 is an average blood sugar of about 180 milligrams per deciliter, which is about 2.5 times, maybe more, maybe close to 3 times the usual blood sugar of non-diabetic children. Non-diabetic children tend to run in the around 65 milligrams per deciliter. So the ADA is now advocating blood sugars under 3 times normal, and the reason they give is because children with higher blood sugars are more likely to develop complications of diabetes, including poor growth and development in general. So the ADA finally is recognizing the fact that high blood sugars can cause complications in children, but they're still seeking relatively high blood sugars because they're afraid that kids will get such severe hypoglycemia that they may die and their doctor may get sued. Here's another recent article, Association of Serum Vitamin D Concentrations with All-Cause and Cause-Specific Mortality Among Individuals with Diabetes. And in this study, the lowest quartile or quintile of vitamin D levels were compared with the highest serum vitamin D levels, and those at the lowest levels had more cancer, more heart disease, and a number of specific causes of mortality than did those who had the highest level of vitamin D in their serum. So certainly in parts of the world where you're not exposed to the sunlight, vitamin D supplementation is warranted, and I've been saying this on my videos for years. Clinical impact of C-peptide secretion in type 1 diabetes on glycemia and microvascular complications. Again, a reiteration of what I've been teaching for years, namely that it pays to preserve beta cell function. If you start treating diabetes aggressively from the onset, you stand a chance of preserving beta cell function because high glucose is toxic to beta cells. So if you can preserve, and here they're talking about C-peptide secretion, which is a measure of ongoing beta cell activity. As long as we can measure C-peptide levels in your blood, which is a byproduct of insulin, of your own insulin production, you are in better straits across the board. It means that A, you're continuing to make insulin, but B, your blood sugars are probably going to be much lower and less variable than the people who are making no insulin. So I'm very aggressive when I treat my patients in trying to catch them early and normalize blood sugars as rapidly as possible, and to keep them relatively level, not varying wildly. Another recent article, association between achieving inpatient glycemic control and clinical outcomes in hospitalized patients with COVID-19. Now, many of my viewers have asked, does blood sugar affect survival from COVID-19? And in the past, I've said, I would think so, but I don't know. There have been no studies. Well, here's a study of inpatients, and what they find is two things. If you enter the hospital with high blood sugars, or if after arriving at the hospital, you develop high blood sugars, either from the stress of the disease or maybe from the steroids that they give you, those who either arrive with high blood sugars or develop high blood sugars after arrival have poorer survival than those who do not have high blood sugars. So this answers the question that many viewers have already asked. High blood sugars do not help, well, high blood sugars hinder survival from COVID-19. I'll repeat that because we had a beep. High blood sugars hinder survival from COVID-19. Here's an article in the New York Times. I believe it's from the science section this month. When should you work out? Well, for years, I've been pointing out my observation with diabetics, especially type 1 diabetics, that when you work out in the morning, blood sugars tend to go up. And when you work out in the afternoon, depending upon the intensity of workout, you're more likely to have blood sugars that go down. So I've been encouraging my patients to work out in the afternoon. And lo and behold, it seems that even in non-diabetics, the results of the workout, that is, the effects on things like muscle strength, heart disease prevention, and so on, are better amongst those who work out in the afternoon. I did not realize that my rule for diabetics would also apply to non-diabetics. New York Times. Now, here's another article relating to COVID-19. This article points out that one of the adverse effects of COVID-19 is to increase platelet aggregation and blood clotting. And this particular study recommends dipyramidol, which is a platelet antagonist that also happens to be antiviral. And this is an article in the Journal of the American Medical Association. So it's something for doctors to think about. I imagine that it's probably a pretty important idea, and maybe they should be giving this to people as soon as they develop COVID-19 infection. Now here's another important study reported in a journal of the American Diabetes Association. Not only diabetes, but also prediabetes leads to functional decline and disability in older adults. And by functional decline and disability, they did a number of tests, whether you can stand up from sitting in a chair without outside help, how rapidly you can walk across the room, tests of cognitive ability and memory, etc. And prediabetes was defined as an A1C between 5.7 and 6.4. Now, 5.7 is an average blood sugar of approximately 128. So again, this reiterates something I've been saying for years, that even slight blood sugar elevations can cause damage if they occur over a long enough period of time. We've attached to this video a copy of an announcement by Eli Lilly and Company that the FDA has granted them emergency authorization to produce some new antibodies for the treatment of COVID-19. And it's recommended that it's a combination of two antibodies that Lilly makes to be given when a person initially becomes sick with a disease, especially if they're high-risk individuals or if they have moderate symptoms. In other words, not just a very mild disease, but it looks like they're going to get worse. They should be given these two antibodies. And this is a new announcement from Lilly, and you can get a copy of it with this video if you look carefully on your screen. Now we can finally get on to our questions for the month. But first I should remind you that my answers are generic answers. The questioner cannot give me their complete medical history, nor can I do a physical exam on them. So I can only guess at an answer to their question. And I'll give you an example. One lady asked, why do my hands go numb when I sleep at night? Well, all I can do is guess. And my guess is that she sleeps on her belly with her hands under her pillow and her head on top of her pillow, and the head pressing on her hands all night long, call the hands to get numb. And when she takes the hands out from under the pillow, they won't be numb. That's a guess. It's an educated guess, but it's a generic answer and a guess. And all my answers are going to be like that. Type 2 diabetic and nearly off insulin with an A1C of about 5.8%. Well, right off the bat, we see that her average blood sugar is about 140, and it may or may not be varying widely about that. I very closely follow your low-carb diet and do not cheat. Should I keep taking a small amount of insulin, basal or bolus? I do not have a continuous glucose meter. Would that help me to determine my insulin strategy? Well, it might help. I require that my patients who take insulin get a continuous glucose monitor. I don't know whether you are going to require insulin or not, but for an average blood sugar of 140, you should be doing something. I'd suggest you read my book and see what it recommends, but I wouldn't be satisfied with an A1C of 5.8. I would try to get it down. And what that something should be is up to you. You have to look at all the possible solutions, and insulin indeed is one of them. You might need a very small dose of a long-acting insulin like Tresiba, maybe a unit or a half a unit a day. You might need small amounts of insulin before meals. You might even do well with diluted regular insulin before meals. But I'd suggest you read my book and experiment. It certainly helps from a safety point of view to have a continuous glucose monitor, especially if you're experimenting. I am new to Tresiba, and I've started with Tresiba 2 times a day. I take my night dose around 10 p.m. at bedtime and a morning dose around 6 a.m. I notice that I sometimes go low around 4 a.m. Is this due to my morning shot or my night shot? Well, it would depend, amongst other things, on the size of the doses. If you're taking a very large morning dose and a small dose at 10 p.m., it would probably be due to your morning dose. On the other hand, if they're 2 equal doses, it would be more likely due to your nighttime dose. So, and again, as I've said over and over, a lot of this depends upon trial and error and experimenting. And of course, a continuous glucose monitor is very helpful, both in giving information and in keeping you safe if you use a CGM that has an alarm. A CGM that merely enables you to wave the receiver near your sensor and give you a number is not going to wake you up at night with an alarm. I've been following your method for about a year, and my A1C has dropped from 8% to 5%. One thing that has not changed is that I feel tired during the late afternoon. I thought this would change with normal blood sugars. Could it be something else? Yeah, it could be a lot of things. One thing it could be would be a low blood sugar. So if you have a continuous glucose monitor, it might pick up, well, you don't even need that. You just need a blood sugar meter. And if you're low, you check your blood sugar when you're tired. And if you're low when you're tired, you have an answer. But another common answer would be low thyroid. If you have low free T3, you could be tired any time of the day or even all day long. There are other things that can cause tiredness, for example, anemia. And if you can't figure out on your own what's causing it, you certainly should pose the problem to your physician, because this should be up his alley. He would know what tests to do to try to figure out what's going on. The low-carb diet is likely also low in fiber and plant diversity, which is critical for microbial diversity. I am keen to pursue your approach, but also mindful of this impact on the biome. How do we best approach optimizing our fiber diversity with your approach? Well, if you compare my approach to the average American diet, or to what most people are doing who follow ADA guidelines, you're comparing my approach, string beans, to French fries. And certainly the string beans are going to have a lot more fiber than the French fries. And if you look in my book, Diabetes Solution, you'll find one page that lists something like 40 different low-carb vegetables. And this is a far cry than the average American diet, or than the high carbohydrate diet of the ADA, which recommends a lot of pasta, whole grains, etc. I have two daughters, 8 and 12, with type 1. Thank you for writing the best book and probably the only one on how to normalize blood sugars. My older daughter, some nights around 3 a.m., while sleeping, I notice the CGM, a sudden rise in her blood sugar, say from 100 to 180. Wow. My question, what may cause this? Maybe she has gastroparesis, but not sure. Any other causes? Well, gastroparesis would show a low blood sugar after dinner and then a high blood sugar a number of hours later. So that is a possibility. But it would only be likely if she's had if she's had type 1 diabetes for a number of years. Now, I had symptoms of gastroparesis only 4 or 5 years after I got diabetes. But we had no idea what my blood sugars were. We didn't have blood sugar self-monitoring. And I would go to the doctor's office once a month, and sometimes it would be 60, and sometimes it would be 400. So I probably had a lot of very high blood sugars. That's why I had such rapid onset gastroparesis. And I only knew it because, I knew it now, because I had burning, retrosternal burning after meals, and I felt very full and bloated after meals. Now, she has none of those symptoms, and if she's only been diabetic, let's say 2 or 3 years, and hasn't had, well, she did have high A1Cs in the past, so we don't know whether she has gastroparesis, but she may be growing. And the production of growth hormone usually is maximized while you're sleeping. And it would be a good idea on a day that she had high blood sugars at night for her to get growth hormone checked the first thing the next morning. So you could take her to the lab, or have a doctor give her a lab order form to bring for a human growth hormone. And since she's 12 years old, she might have high levels of sex hormone binding globulin, which, according to a recent study published, I believe, in the journal Diabetes Care, is associated with high blood sugars. So if you're near puberty and have high levels of SHBG, sex hormone binding globulin, that can also cause high blood sugars. So you should check that. So we check both growth hormone, human growth hormone, and sex hormone binding globulin the morning after a night when she's had the high blood sugars. My daughter was diagnosed at age 7. Now at 21, despite gym and pump, she is overweight, and her blood sugars are all over the place. Well, right off the bat, if she's on an insulin pump, the chances are that she's being given too much basal insulin and forced to eat to compensate for the over-insulinization. Now, that's a guess, just speculation on my part. Trying to encourage low-carb eating, but wondering how to treat lows without reintroducing too much sugar. Well, first of all, I'd suggest that you read my book. I suggest that you switch to basal bolus injected insulin like we recommended in the book, and not go to the insulin pump where you've created a lot of scar tissue at the pump sites and don't know how much insulin is being absorbed from the pump, so that you're getting random inputs of insulin. And I also recommend that you use liquid glucose, which is the most rapid thing we have for treating low blood sugars. Now, you want to avoid glucose, but by avoiding the low blood sugars or the up and down fluctuations of blood sugars, you can minimize the amount of liquid glucose that you consume. Now, I always have liquid glucose handy for me. I take small amounts if I'm low. 1 teaspoon will raise my blood sugar by about 12 milligrams per deciliter. And it's nice for fine-tuning the low blood sugars. As a type 1 diabetic that is already prone to autoimmune disease, should I be concerned about receiving the new messenger RNA COVID vaccine? No, you shouldn't be concerned, because the antibodies that the COVID vaccine is going to stimulate are antibodies to particular viral proteins, not to your proteins. Your own body proteins are totally different than the viral proteins. And these are usually spike proteins that are attacked by the COVID vaccine. So one doesn't have anything to do with the other. The fact that you're prone to autoimmune diseases is not going to enable the vaccine to cause you harm. We know your method, we follow your method for our 11-year-old child who was diagnosed with type 1 diabetes. We noticed that often when she exercises, she goes high instead of low. Although she starts exercise in a good range, but after exercise, she would go over 117. Because of that, we don't give her glucose before or during exercise. However, she would sometimes go down a few hours later. Should we be doing something different? Well, first of all, as I've said before, we should exercise in the afternoon or evening, not in the morning. Because if you're too close to the dawn phenomenon in the morning, your basal insulin may not be adequate to cover the exercise. Everybody needs insulin when they're exercising, and diabetics likewise. But the insulin that a diabetic is getting is usually the basal insulin that was injected sometime prior. And in the early morning hours, let's say from the time you awaken to maybe 4 hours later, your liver is destroying some of the basal insulin that's getting into your bloodstream. So we find that a lot of people have blood sugars that go up when they exercise in the morning. In addition, we have Elliot Jocelyn's warning, which I've cited over and over. It's the only thing that I remember him telling me when I was 12 years old. He said, never run a block for a bus. If you're going to run for a bus, run a mile. And the message was that exercise stimulates the production of counter-regulatory hormones, hormones that raise blood sugar. And you're going to have to do a lot of exercise to offset the effect of the hormones that raise blood sugar. And so one way around that is to take propranolol, which stops some of the counter-regulatory effects. And I've used it on some of the kids that I treat prior to their exercise, and indeed it frequently works, but not always. So you try a small dose, like 5 milligrams of propranolol. It doesn't seem to do them any harm, and I've spoken to several pediatricians who say there's no harm in this. And for some of these kids, it works. Sometimes it works on some people it works all the time. On some people it works only some of the time. I have yet to find anything regarding blood sugar rise after hot showers. My blood sugar has been rising by 10 to 40 milligrams per deciliter on my Dexcom, and I thought it was a sensor issue, but I have finger pricked, and it has indeed gone up. It is not in the morning, so I don't think it's the dawn phenomenon either. I would be grateful for you if you have any information on this. Well, I actually went to the internet and looked up to see if hot showers stimulate the sympathetic nervous system, the nervous system that causes hormones that raise blood sugar, and sure enough it does. So you're going to be making epinephrine and other hormones that raise blood sugar, and indeed hot showers can raise blood sugar. I am hungry 2.5 to 3 hours after eating. No one is here where I reside to help me with this. How do I cope? I've tried the doctor's diet and fail because of hunger. I've read the book. Well, if you've read my book, Diabetes Solution, but the latest edition, the 2011 edition, which is already 10 years old, we do measure SGLT1 agonists, which can enhance satiety after eating. So that's the only thing I can think of off the bat. I wish you luck. You could ask your doctor to try prescribing an SGLT1 agonist. You have to beware if you already have liver disease, gallbladder disease, because these agonists can foster pancreatitis. And I have had several patients who developed pancreatitis while taking these drugs, and the pancreatitis stops when you stop the drug. If we are following your diet, depending on a high amount of protein instead of carb, isn't that going to damage the kidney by long-term intake of protein? Well, it's interesting that there's still a number of doctors who say that it's protein that causes diabetic kidney disease, when it's really high blood sugars that cause diabetic kidney disease. And if you have high blood sugars, you're much more likely to develop kidney disease than those who have normal blood sugars. So I would say that you don't worry about the protein. There have been studies of end-stage kidney disease where they gave people high protein and low protein, and except at the very, very tail end, the amount of protein in the diet when you're almost ready for dialysis may make a difference. But as far as people without kidney disease, shouldn't make any difference. Another break.
Why don't you tell the story of where that fits?
Okay, do I now I've told it in the past. Should I do it again? Okay. Along the lines of the protein and kidney disease myth, many, many years ago, Barry Brenner at Harvard did a study with diabetic mice. And he went to the diabetologists in Boston, asking where they like to keep their type 1 diabetics, what blood sugar. And the universal response was about 250 milligrams per deciliter. So that's where he kept his muses. And he found that the mice at blood sugars of 250 who are on high protein diets developed diabetic kidney disease about 3 times as rapidly as those on ordinary rat chow. All of the rats died of diabetic kidney disease, but the ones on high protein diets died more rapidly. So he concluded that diabetics should be on low protein diets. Now, Barry Brenner came to New York, where I live, and made a presentation to an American Diabetes Association meeting, and his presentation was at the NYU School of Dentistry. I remember the building, and this was probably 40 years ago. I had just graduated medical school, and there was going to be a business meeting of the ADA right after this scientific meeting. And my application for senior member of the ADA was going to be voted upon. So Barry Brenner took a vote of the audience. How many of you support this blood sugar of 250? And everyone in the audience raised their hand. And then he said, well, you all agree with the blood sugar we used. And I stood up and said, just a minute, I disagree. I think that diabetics are entitled to the same blood sugar as non-diabetics. And I got a big boo from the audience. And you can guess what happened to my application for senior membership. Anyway, about 5 years later, I was in practice, and I was doing a joint research project with John Lariff, who was the pioneer in the development of ACE inhibitors to treat hypertension and kidney disease in diabetics. And he had a research fellow with him from Scotland, Gordon Bell. I have a good memory. And I worked with Gordon Bell to give him diabetics with normal blood sugars, where he was testing atrial natriuretic factor to see whether diabetics had higher levels of ANF than non-diabetics. And he needed some diabetics with high blood sugars, which they had at the New York Hospital where he was working. They couldn't find any diabetics with normal blood sugars, so I became a source, my patients. And Gordon went to the annual kidney conference to present his data, which showed that the normal blood sugar diabetics had normal levels of ANF, and the ones with high blood sugars had abnormal levels. And lo and behold, Barry Brenner was presenting a paper. And Gordon heard the paper, and he actually sent me an abstract. It was an abstract of the whole conference. And Barry Brenner this time kept the rats at normal blood sugars and found that the high protein diet not only did not cause kidney disease, but that those at normal blood sugars had normal rat lives on the high protein diet and never developed diabetic kidney disease. Even though they were diabetic rats, they were clamped at normal blood sugars and they did not develop kidney disease. So this undid his prior studies, and his prior studies attracted a lot of attention because Harvard put out a press release and sent him around the country on a speaking tour of his great discovery that protein caused kidney disease. Now that he proved that protein did not cause kidney disease, Harvard did not issue a press release. He was not sent around the country. He only attended the kidney conference, and he did not publish these results in any journals. It was only in the archives of the kidney conference. And years later, I contacted the National Kidney Foundation and tried to get a copy of the archives because I had lost my copy, and they had discarded them all. So that's a long story. What is the longest amount of time someone has been in the honeymoon phase? In my experience, I have, I think, at least 2 patients who are still taking the same amount of insulin they were taking at the time of diagnosis. And it's been 20 years in one of them and 30 years in another. And they might last longer, they're still alive. Does anyone else have issues with high blood sugars while traveling? Well, I guess this listener or viewer has trouble with high blood sugars when traveling. And I've seen plenty of patients who have high blood sugars when they don't stick to their diet. I've had some extremes of what people will do to follow their diet to keep their blood sugars normal. And one of the extremes was a lady who traveled to Russia and was away for something like a month and had a trunk full of tuna fish cans. to be able to stay on her diet. And I've had other people go to similar extremes to stay on their diet while they're traveling. I try to give people ideas of what you can get when you're away in a foreign country. For example, I tell people that I discovered when I was traveling in my youth, had more time available. I was an employee, and I was up to 3 weeks vacation time. And I discovered that the international word for something I could eat was omelette. Wherever you go in the world, you say omelette, you're going to get the same thing. So I was lucky. If we can manage type 1 diabetes blood sugar at normal levels, would it reduce the chances of getting thyroid disease? I doubt it very much. I've had many patients who had thyroid disease before they developed diabetes, usually hypothyroidism, and of course many patients who developed hypothyroidism years after they developed diabetes. I'm a type 2. My blood sugar is sometimes in the 200s, even with very low carb. Should I try metformin? You should try to read my book, Diabetes Solution. There are many options, and the options go from, are you really following a low-carb diet, to adding exercise, to adding metformin, to adding insulin, etc. I rarely prescribe many of the currently advocated drugs for treating type 2 diabetes because of potential side effects. But you could read about this in Diabetes Solution. I am overwhelmed with what you can and can't eat. There are some things that at this point I just can't imagine not eating. Onions. We'll start here. Can someone tell me what the deal is with them? I am so depressed. Well, I guess this person likes to walk around smelling like onions. What I say in my book, and have said to many of my patients, is that onions are sort of halfway between vegetables and fruits. If you have one slice of onion in a salad, it probably won't make much difference to your blood sugars. But if you have a stack of onions, it'll probably have a significant effect on your blood sugar, and you may not be able to control your blood sugar with insulin because the stack may work faster than the insulin. And you certainly are not going to have people who want to cluster near you. So during the COVID epidemic, I guess there's reason for eating a stack of onions, but from a blood sugar point of view, it's not such a good idea. What is your favorite vegetable? I think my favorite is sauteed mushrooms. But I haven't eaten many of the vegetables that Uncle Wiggily, the bunny rabbit gentleman, used to like rutabagas. I don't even know what they look like. But of the ones that I've eaten and tasted, sauteed mushrooms. Do you know if the increase in blood clotting due to COVID in some cases, if that might affect the eyes? I'm getting checked out tomorrow morning for symptoms of an eye stroke. I'm wondering if it may be due to COVID. I think it happened a few weeks ago. Well, you can search the internet as well as I can. We do know that COVID can increase coagulation. I've mentioned that before. So it's certainly a possibility. When you visit your eye doctor, you can ask him what he thinks. You can be tested for COVID antibodies to see if you've had it. That's about all I can tell you. You can certainly check the internet, probably a lot better than I. What kind of type 2 diabetic meds do you commonly prescribe? Number 1 is Metformin. Number 2 is insulin. And I'll prescribe GLP-1 agonists to curb appetite. They only have a small direct effect on blood sugar, but sometimes they have such a significant effect on appetite that will lower A1C considerably. But it doesn't work for everybody. And another potential problem with the GLP-1 agonists and with everything I've tried to curb appetite is that for many people, let's say for half the people, they become tolerant of it after a while, so that their appetite may be curbed for a few months, but then it comes back. So it's difficult to use GLP-1 agonists. It may work, may not, and you may develop a tolerance. One thing that I do want to look at is transcranial magnetic stimulation, which is a new treatment that some research centers are using to treat overeating. And we have a local source and a doctor who's doing this, but I have yet to try it for people who are overeating. Well, thanks for watching this teleseminar. Our next one is going to be Wednesday, April 28th, 2021. Stay well, wear a mask, and enjoy life.